Welcome everyone to this USMLE Step 2 CK tutorial on chronic kidney disease. CKD is one of the highest yield nephrology topics on Step 2. You can expect multiple questions on staging, complications, drug dosing, and transplant evaluation. In this session, we will walk through 5 clinical vignettes that mirror the style and difficulty of actual board questions. My goal is not just to help you get these questions right, but to teach you the test-taking pattern recognition that will pay off across dozens of similar stems. For additional practice and one-on-one tutoring, visit roadmap2residency.com. Here are our 4 learning objectives for today. First, staging. You must have the GFR cutoffs memorized cold, because board questions will hand you a creatinine or GFR value and expect you to identify the stage in 5 seconds. Second, complications. Anemia, mineral bone disease, acidosis, and hyperkalemia all have classic triads the exam loves. Third, drug dosing. Knowing which medications to stop, adjust, or avoid in CKD is tested repeatedly. Fourth, transplant evaluation. This is a smaller topic, but almost guaranteed to show up at least once. By the end of this tutorial, you should be able to attack any CKD stem with a clear mental framework. Let us build your framework. Step 1 is knowing your stages, and you absolutely must commit these numbers to memory. Stage 1 is GFR above 90 with evidence of kidney damage. Stage 2 is 60 to 89. Stage 3A is 45 to 59. Stage 3B is 30 to 44. Stage 4 is 15 to 29. And Stage 5 is below 15, which is end-stage renal disease. Step 2 is identifying complications. The exam wants you to know that anemia typically appears around stage 3 to 4 due to decreased erythropoietin production. Mineral bone disease involves phosphorus retention and vitamin D activation failure. Metabolic acidosis and hyperkalemia worsen as kidney function declines. If you struggle with these concepts, review the nephrology sections in First Aid and UWorld. Before we jump into cases, let me give you 3 buzzword associations that are worth their weight in gold. Number 1. Normocytic normochromic anemia plus low erythropoietin plus advanced kidney disease equals CKD-related anemia. Number 2, bone pain plus high PTH plus low calcium plus high phosphorus equals renal osteodystrophy. This 4-part combination is pathognomonic. Number 3, confusion plus asterixis plus very high BUN equals uremic encephalopathy, which is an indication for urgent dialysis. When you see these triads in a stem, your answer should almost write itself. Train your eyes to pattern match on these buzzwords. Let us work through case 1. A 58-year-old woman with a 15-year history of type 2 diabetes comes in with progressive fatigue over 6 months. Her labs, hemoglobin 8.2, MCV 88, so this is normocytic, creatinine 2.8, and GFR of 22. Iron studies and B12 are normal. The question asks, what is the most likely cause of her anemia? Pause here and think through it before I reveal the walkthrough. Notice the clues: normocytic anemia, a diabetic with long-standing disease, GFR in the low 20s, and critically normal iron and B12 studies ruling out the most common outpatient anemia causes. Here is the 3-step walkthrough. Step 1, analyze the clues. Normocytic anemia with normal iron and B12 in a diabetic with GFR of 22 means stage 4 CKD, and diabetes is the #1 cause of CKD in the United States. Step 2. Apply test strategy. When the exam gives you normocytic anemia plus advanced CKD plus normal workup, they want erythropoietin deficiency. This is a classic 2-step question testing both the anemia workup and kidney staging. Step 3. The correct answer is decreased erythropoietin production from CKD. Treatment is erythropoiesis-stimulating agents like epoetin alpha or darbepoetin, typically started when hemoglobin drops below 10. Before starting an ESA, always check and replete iron stores first. Case 2. A 63-year-old man has been on hemodialysis for 4 years. He presents with diffuse bone pain and proximal muscle weakness. His labs show calcium 7.8, low, phosphorus 7.2, high, PTH 800, very high, and alkaline phosphatase elevated. The question, what is the most appropriate initial treatment? Take a moment to think. Look at that triad. Low calcium, high phosphorus, sky-high PTH. That is your pathognomonic combination. Now, what do you treat first? This is where students commonly go wrong, so let us break it down carefully on the next slide. Step 1. Recognize the pattern. High phosphorus plus low calcium plus very high PTH equals secondary hyperparathyroidism from CKD mineral bone disorder. Commit this triad to memory. Step 2. Understand the pathway. The failing kidneys cannot excrete phosphorus, so it accumulates. The failing kidneys also cannot hydroxylate vitamin D into its active form, calcitriol, so calcium absorption drops and hypocalcemia develops. Both hyperphosphatemia and hypocalcemia stimulate PTH release. PTH then drives bone resorption, causing the bone pain and weakness you see in the stem. Understanding this pathway helps you figure out what to treat and in what order, which brings us to the next slide. This is the high-yield management slide, and the boards love to test the order of operations. First priority, control phosphorus. Start with dietary phosphorus restriction and add phosphate binders taken with meals, sevelamer, lanthanum, or calcium acetate. If the patient is already hypercalcemic, avoid calcium-based binders and pick a non-calcium binder like sevelamer. Second priority, active vitamin D, meaning calcitriol or paracalcitol, to suppress PTH. And here is the key test point. Only give active vitamin D after phosphorus is controlled. If you give vitamin D while phosphorus is still high, you drive calcium up and raise the risk of calciphylaxis and vascular calcification. So the answer to case 2 is start a phosphate binder first. Case 3. A 70-year-old man with stage 4 CKD and GFR of 18 comes in to establish care. His medication list: metformin for diabetes, lisinopril for hypertension, and naproxen for knee arthritis. The question: which medication should be discontinued? This is a very common exam format. Give you 3 or 4 home medications and ask which ones need to go. Look at the GFR, think about each drug individually, and remember that when more than one drug is problematic, the exam usually wants the one causing the most immediate harm. Step 1. Review each drug. Metformin is contraindicated when GFR drops below 30 because of lactic acidosis risk, so it has to go. Lisinopril can be continued, but you must monitor potassium and creatinine closely. It actually has renoprotective effects in diabetic CKD. Naproxen, and all NSAIDs, should be avoided in CKD because they cause afferent arteriolar vasoconstriction, which triggers acute kidney injury and accelerates CKD progression. Step 2. Apply the rules. When multiple drugs need attention, prioritize by harm. The correct answer is discontinue naproxen first because it is actively injuring her kidneys right now. Metformin should also be stopped given the GFR below 30. On a single best answer question, naproxen is your answer. Case 4. A 45-year-old woman with end-stage renal disease from polycystic kidney disease is being evaluated for kidney transplant. She has been on hemodialysis for 1 year. Her cardiac workup and cancer screening are normal. The question: which of the following is a contraindication to kidney transplantation? Transplant evaluation questions typically offer you a mix of answer choices. Some are absolute contraindications, some are relative, and some are distractors like advanced age. You need to know which bucket each falls into. Here are the 3 buckets. Absolute contraindications, and these are what the exam is testing for: active malignancy, active untreated infection, severe irreversible cardiac or pulmonary disease, active substance abuse, and poor expected survival of less than 5 years. Relative contraindications include obesity, which may require weight loss first, and prior malignancy, which requires a cancer-free interval of typically 2 to 5 years depending on the cancer type. Test-taking strategy. The exam will often dangle advanced age or obesity as answer choices to tempt you. Remember, age alone is never a contraindication. Look for the choice that represents an active, ongoing issue that would make chronic immunosuppression dangerous. That is your answer. Our final case. A 52-year-old man with CKD stage 3B presents for follow-up. GFR is 35. Labs: potassium, 5.8, mildly elevated, bicarbonate, 18. That is metabolic acidosis. Which medication should be started? The choices: A. Sodium polystyrene sulfonate daily. B. Sodium bicarbonate supplementation. C. Furosemide. Or D. An ACE inhibitor. Pause and work through the answer choices. Notice they are asking which to start, not which to avoid. So identify the primary abnormality the exam is highlighting, then match the treatment. Why B is correct. The bicarbonate of 18 tells you the patient has metabolic acidosis, which is very common in CKD. Sodium bicarbonate supplementation has been shown to slow CKD progression and is guideline recommended for patients with CKD and acidosis, and this is increasingly tested on the boards. Why the others are wrong? A. Sodium polystyrene is for acute hyperkalemia, not daily chronic use, and has GI side effects including colonic necrosis. C. Furosemide does not directly address the acidosis. It might help potassium modestly, but it is not the best answer. D. An ACE inhibitor would worsen the hyperkalemia and is a common trap answer for students who remember ACE inhibitors are renoprotective. Thank you for joining this walkthrough. For more high-yield content and tutoring services, visit roadmap2residency.com and please like and subscribe.